Thank you, Mr. Chair, and I really want to thank all of our witnesses for testifying before the committee today. As a physician, military veteran, and a former director of public health, I think that this discussion is fascinating, and you've actually answered some of my questions as we've gone along. I'm glad to see the committee include my bill with Mr. Carter, the Telehealth Modernization Act, in the hearing today, and your mentioning of that bill. This bipartisan legislation expands audio-only telehealth access for seniors and maintains provisions and originating site restrictions for rural patients. As a matter of fact, as a state senator, I was able to pass in one session a bill that included schools as a site of service for behavioral health and for mental health for middle school and high school students. Amongst other policies, the legislation allows federally qualified healthcare centers to furnish telehealth services. Unity Point, a hospital system in Iowa with locations and clinics in my district, had 1,689 providers serve 76,268 patients via telehealth in the past year. This resulted in over 160,000 telehealth visits, with 94% of them occurring in the outpatient setting with high levels of patient satisfaction. And part of this was not just the pandemic, but part of this was technology reaching the platform where multiple people and imaging was at the level. So those things happened concurrently with the pandemic and led to high rates of success. It also allows seniors, and especially those in rural areas, to have consistent and reliable access to their physicians, which is critically important for individual and public health. And Dr. Mirorta, I very much appreciate your talking about the cost structure, the reimbursement. I have long, even though I have advocated for telehealth and was part of getting the exemption prolonged, that would the waivers for the exemptions during the pandemic, trying to make those permanent. I also don't believe 20% reimbursement for telehealth is adequate, nor do I believe 100% reimbursement for telehealth is appropriate either, and I've been very honest with my providers and hospitals to that. And also, when we're talking about how we look at telehealth, there is an increased cost in the numbers of visits. There is some overutilization. I think we've seen that when you look at the numbers of visits. And are there things that we should do to either limit providers or limit visits? Incident to billing was brought up. And I think what's important to say is that we need to have data and research that shows if in a certain specialty there are increased numbers of visits versus face-to-face, do those increased numbers of visits lead to better outcomes? Less hospitalization, less emergency room visits. So this question's for Dr. Schwan and Dr. Mirorta. One of the most pressing concerns that I hear from my colleagues in regarding program integrity and the potential for fraud in the telehealth space. What are your thoughts on this issue? What systems has your organization implemented to reduce fraud potential? What policies do you recommend that the subcommittee use to address the potential for telehealth fraud?
Well, I'm going to go out on a limb here and say this is sort of like the boogeyman. I just don't see it. I mean, like I said, we did millions of visits just in that first 6 months. I just think that in general, most providers are just trying to get through the day, see the patients who need to be seen, accommodate the unexpected sick visits, and the ability of telehealth to help us leverage those backfill appointments, the one we just talked about before. It's such a waste if a no-show goes unfilled. I just don't see the fraud, and I haven't seen any articles and any published evidence to support the issue of fraud, and everyone's been looking for it. So I think it's incredibly important to be vigilant about fraud, but we already have mechanisms in place. We have audits. Providers have to attest to the level of complexity or the time spent. We could potentially have even more sophisticated auditing, since these visits are actually measured in terms of the amount of time that was spent on the platform. So I think it's a little bit of a fascination, but I'm not sure that there's real gold there.
But I think we should be monitoring. It's just to emphasize the point that we do need to make sure that the Medicare program has the ability to track these visits very carefully, identify some outliers that might be, and give the Medicare program the ability to remove providers where there's questionable behavior. For example, we have seen some cases where there has some questionable prescribing behavior. The Medicare program needs the tools to track that and then remove those clinicians or those companies in case when those do occur.
Since my time's expiring, I'm going to pose this question and ask Dr. Schwan and Dr. Mirorta and Dr. Cunningham and Ms. Ashlock, if you would respond in writing. So if telehealth access were made permanent, which my legislation does, how would this impact your healthcare system? And the follow-up to that, what should Congress keep in mind this year as we contemplate telehealth permanency? And if Congress were to do another extension of the telehealth flexibilities to have more time to contemplate permanency, how long, in your opinion, would an efficient amount of time to maintain certainty and not discourage the use of telehealth? So I will give that to our staff, and if you could respond in writing, I would appreciate it. With that, I yield back.